So yeah, thank you everyone for coming to join us today. We're thrilled that you all could be here. This is our next installment of our weekly, I guess you call it Zoominar, Be Well Virginia, our town hall meeting. I'm Dr. Ken Zweig with Northern Virginia Family Practice, and we are very excited that everyone could come on for these calls. We have had a great turnout to date. So far, we've had between 100 and 200 people on every call. And so it's really exciting for us that you are all taking time out of your day to listen to us and hear what we have to say, and also take such engagement in your health and your care and your safety. And that's why we're having these town halls, is we want to make sure that everybody is informed as much as possible, and that you are doing all the things that you need to do to stay well and be well. And we're going to continue doing these town halls as long as you want us to. As long as there's more information to share, we're going to continue with these. And so hopefully at some point we can move on from COVID and talk about other issues other than COVID. Someday that will come. There will be a time. In the meantime, we do want to reinforce the idea that there are many other medical issues going on, and that we want you to stay engaged with those. Just because this pandemic is going on doesn't mean that diabetes or high blood pressure or high cholesterol or any of these other conditions have stopped occurring. And we're starting to see those conditions progressing as people are sort of not really ignoring them, but not addressing them as much as they should. So as much as we talk about COVID, we also want to make sure that all of you really address all your medical issues and don't let this pandemic take its toll from some other condition. We're seeing a lot of other conditions really progressing and becoming a problem. So it's all about communication. We want to communicate with you about this and about all of your medical needs. So please call us. We're doing this town hall. We are doing a blog on our website that I've been writing. I've recently got that published in a national publication, which I'm excited about. Dr. Havard has been doing a podcast. We are doing as many things as we can to help keep you informed and engaged as much as possible. So it's a two-way street. So please call us, check our website, continue to come on the town hall. We'll keep doing this as long as you're interested. Some basic housekeeping issues. We are moving, as most of you know, to a new location about a half mile down the street from where our current one is. It's going to be on Beauregard. Everyone seems to think, I guess it's across the street from Clyde's, which I don't know where that is, but everyone seems to use that as a marker. And we're really excited about the new location. It should be terrific. There's a lot of great features about it. And we're doing a lot at the new location to help keep everyone safe for COVID. And I'll have Dr. Beauvais talk about that at the end of this call once we're done with Dr. Casolaro. Also, a lot of you have written in questions for these town halls. We really appreciate that. Please keep the questions coming. We're not always able to get to all the questions, or some of the questions are coming in after we have the town hall. So if that's the case, we've gotten Jessica Ware, our terrific PA, to take it on herself to answer a lot of the questions that we weren't able to address during the town hall. And she's written them out one by one into a blog that we've also put on our website, and we're going to hopefully continue doing that as well. So keep those questions coming. If they're very personal, then we ask you to give us a call if there's a very specific situation. If they're more general, then we're happy to try to address them here or on that blog. So please keep those coming as well. With that said, I'm going to move on to our guest today. I'm so thrilled and excited to talk about our latest guest, Dr. Tony Casolaro, who is a mentor of mine during my years of residency and during my early years as an attending as well. Dr. Casolaro is a specialist in pulmonary and critical care medicine, and he did his training in medical school at Georgetown University, and then did his residency at Emory University in Atlanta at the famous Grady Hospital, and then went on to do his pulmonary training at the National Institutes of Health down the road, where he trained under Dr. Anthony Fauci, who some of you may have heard of. He continued on at the NIH and became the head of the pulmonary department there, which is a very prestigious position, and then moved on to become a pulmonary and critical care physician here in Northern Virginia, where I had the pleasure of meeting Dr. Casolaro. He is currently the lead physician for the Washington Redskins and is the president of the NFL Physicians Association. He's also been a medical consultant to multiple presidential administrations, both parties. So as you can imagine, Dr. Casolaro has fabulous stories and is a wealth of great knowledge and great stories. And we're really thrilled to have you here today and join us for this town hall. So we're going to do things a little bit differently today. Dr. Casolaro put together a wonderful presentation that we're going to have him share for the first 15 or 20 minutes to give you an education in COVID. And then we'll move on to the question and answer session like we did in the past. So with that long-winded introduction, Dr. Casolaro.
Thank you very much. And Ken, I'm really impressed with the practice you've set up and the communication avenues you have for your patients. That's really admirable.
Thank you.
I will add also that when I was in when I spent all those years in the ICUs and when Dr. Kenzweig was a resident, I will tell you that I was always reassured when he was on that night because I knew I wasn't going to get the 2 a.m. call that with a question that I knew he would know the answer to already. And so it's really nice to be at this point in our lives where we can work as colleagues. It's terrific. So what I'm going to do for the folks that are listening, if you give me 15 minutes, I will guarantee you will know more at the end of that than most of the talking heads on television every day. We're going to just walk through some of the background of COVID, and then we'll quickly go to what's gone on now about testing, treatment, and then Ken has already sent some questions which he'll walk through some of the ones that you would like answered, and I will do my best to answer them. I was on a conference call today with the professor from Stanford, who's the infectious disease consultant there, and another from Massachusetts General from at Harvard as part of a committee to try to get the world back together. And how do we do that in the form of sports, which really is a microcosm of starting the world up again anyway. So it's kind of a window into how that can happen. Let me first go to, I'm going to try to share screen and share. Let's see if I can. There we go. You can see it, Ken?
Yep, we got it.
Perfect. Let me just move this over. There we go. Okay. So let's just walk through COVID. We all know where it began. Wuhan, China in the fall. Was it November? Was it October? Was it earlier? Not sure. It's, as we all have read, believed it started in bats and transferred to humans through these live animal markets. Transferred to man, presumably through contamination with these live animal markets where their feces and secretions get on the ground, it gets into humans. A somewhat disturbing, I actually find this among the most disturbing things I'm going to show you. And that is, these are the live animal markets in Wuhan. And I have to tell you, I find this incredibly depressing. Obviously, it's a lot of human cost, and this is where it all began. People ask me, how was this originated? There's a lot of politics around this. I don't think you have to be a super scientist to realize that once it gets into the live animal markets, the fact that it could get into humans doesn't seem like a great stretch. As we've heard, the coronavirus is from the Latin coronam for crown. And as you can see, these little red spikes that we've all seen, looks like a crown. The World Health Organization termed this SARS, this gets confusing. It termed it SARS-CoV-2 virus, or it's also called the novel coronavirus. COVID-19 stands for coronavirus disease, COVID-19. It's not a complicated origin, it's just an abbreviation, but it's called several things, and I think the terminology is helpful to understand. They've existed for centuries. These viruses are the same ones responsible for the common cold, and they account for about 10% of respiratory infections that we all get. This is important. Genetically, the common cold virus as a coronavirus is about 50 or 60% similar to COVID-19. That matters when it comes to testing, so just keep that in mind. SARS-CoV, the first SARS-CoV, was called severe SARS, severe acute respiratory syndrome, SARS. Appeared in China in 2002, Then it became worldwide. We were worried about this spreading worldwide, more than it did. But since 2004, there have not been any cases. This was also felt to originate in bats, and genetically, it's about 82% similar to COVID-19. Then there's another one called MERS, Middle Eastern Respiratory Syndrome. It appeared in Saudi Arabia in 12, but there's only been 2 US cases. Again, felt to originate in bats, and curiously felt the intermediate animal was a camel, which is how it got its name and where it came from. So how does this work? Why do people get sick from it? Okay, let's look at this. So the virus, which is up top where it says virion, this little round thing with the spikes, attaches to a human cell at a receptor. The receptor, once it attaches to the cell, it directs and it gets inside, it makes the human cell start making the building blocks of the virus to enable it to make more virus. And then after it makes all the building blocks, it is extruded from the cell, and you'll see it up at the top where the arrow's coming out. And it's like it takes over the factory, making more COVID-19 cells. And by the time it does that, the machinery of the cell is not making anything to keep the actual human cell going, and the cell dies, the human cell. What are the symptoms? We all know, we've read, fever, fatigue, dry cough, maybe muscle aches, runny nose, sore throat, shortness of breath, and sometimes GI symptoms. The typical symptoms, this is helpful to look at. Fever, we all think of fever. We all have asked, you get to an office or a hospital now and they check your temperature. It's a high number, but it's still not 100%. About 87, 88% of people have a fever. Dry cough, really just over 2/3. Fatigue, a little over 1/3. Sputum, less common. Shortness of breath, less common. The typical symptoms of the, quote, flu, which is headache, sore throat, not very common, as you'll see, 13, 14%. But the big 3 we think of are still fever, dry cough, and fatigue. The classic symptoms, again, just to keep those in mind, I think if those are the 3 we remember, but curiously, the shortness of breath is not a large percentage of people. Fever and dry cough are really the more dominant. How do you make a diagnosis? You have symptoms, fever, cough, fatigue, congestion, which may progress to shortness of breath. You may get muscle aches or a sore throat, loss of smell and taste, still a small number, about 5 to maybe 10%. And then diagnostic tests. The diagnostic tests that everybody's talking about testing are nasal or throat swabs that are based on a technology called PCR, polymerase chain reaction. What the heck does that mean? We'll come back. COVID-19 diagnosis, the swabs test for the presence of the virus using this test PCR. If you have the active infection, it'll be positive from maybe 1 to 2 days before you get symptoms until the infection clears, maybe up to 14 days. Blood tests, again, separate testing. There's swabs which look for the virus and blood tests which look for antibodies. Antibodies are the immune response to the infection. These aren't present for about a week after you get an infection, although they may remain for years. Now, what is a PCR? So this slide depicts what happens. Number 1, you take the swab from the nose or the back of the throat. You send it to the lab, as you'll see. Number 2, they take the RNA, not the DNA. They take the RNA is purified from the virus and convert it into DNA using an enzyme. They actually use an enzyme in the test. So the reason this matters is you've got to have material. You can't just put it in a machine and get an answer. You've got to have material which a lab has to make. So not only do you need swabs, but you need what are called the reagents to help amplify the virus so that they can actually measure it. And number 3 just shows how it's done. It basically duplicates the virus, magnifies it, uses a fluorescent dye, and then they can see on the far right at the bottom, if the dye lights up, you've got the virus. It's very sensitive. It's just, it requires several steps and it requires equipment. You need the machine, you need swabs, and you need material to do the test in. And that's been the problem. The diagnostic tests, there are several labs that do these nasopharyngeal swabs. Quest, LabCorp, hospital-based, Mayo. They take 1 to 3 days to get the results. Now the backlog is gone. And the machines that we use at the hospitals and at the Quest and LabCorp, they can do, honestly, dozens of tests at once. There's also, they talk about these rapid tests. It's also done by the same biology called PCR, but it's a point of care test. And this is where the way people talk about things get confusing. So these rapid tests can be done, they're small machines, they're available now at most hospitals. Inova and Virginia Hospital Center in this DC area and MedStar all have these point of care tests. The problem is they're only done one at a time. So unless you have 10, you can do maybe 3 or 4 in an hour. So most of the hospitals have 4 to 10 machines, and that's how they get a rapid test. The ones they send out take 1 to 3 days. So that's, if you go to the emergency department now, they may do a rapid test, get the result in an hour, but remember, they can't do a population. Populations are only going to be done by doing the tests that take a couple of days. And I wrote down some of the other technology that's available. So rapid tests can be done, they can take 5 to 15 minutes or a couple hours, limited in supply, and they're only done right now in emergency departments, and then only on patients that are going to be hospitalized or have procedures done. And here's the problem. Those tests can be negative up to about 30% of the time, even if you have an infection, because you may be too early, or maybe you didn't sample the throat properly. It's like when you were a kid and you bring your kids to the doctor, they do a throat swab for strep. You got to try to get it way back there and get the sampling. Same thing is true. If you don't get a good sample, you're not going to get a good result. By the way, it's not a pleasant test to have done. That's, I think, it's got, antibody tests detect exposure and immunity. That's a blood test. That you've got to wait about 7 days after infection, and then you look for antibodies. These are also done as a batch. You can do a whole bunch at once. There are point of care, these ones where they talk about pricking your finger to see if you're immune. Those have not, there's not a single one that I'm aware of that's felt to be reliable as of today. The one at Stanford looks like it might be as of this morning, but I don't know that that's been published yet. There are a lot of people are trying to develop antibody tests. We'd like to know who is immune so far. You can assess immunity with these antibodies. To open up the country, we're going to have to know who's got it and who's immune and potentially no longer at risk, although we'll talk later about how debatable that is. So how do you do an antibody test? Well, an antibody test is a blood test that looks for proteins that your body reacts against. Remember we said before the common cold is about 60% similar to COVID-19? Because of that, you can get cross-reactivity. So you do a blood test and it says, hey, you're immune to COVID-19. Maybe not. Maybe you're just immune to the common cold because the antibody test wasn't specific. And a lot of these things are being sold now online and people are promoting them. We're worried that they're going to show immunity to the common cold, or excuse me, antibodies to the cold and not to COVID-19. Because a test that shows you have antibodies, it's incorrect, will put you and other people at risk. That's why it's such a big deal. How do you treat it? Supportive care, you remain at home for mild cases. If you get short of breath, which is about 15% of people, you may have to go to the hospital and get oxygen. About 5% of the people hospitalized may end up on a ventilator. What's the prognosis? The vast majority of people are going to have mild to moderate disease. I can use my son as an example because he doesn't care about HIPAA. 35 years old, developed COVID about 5 weeks ago, was sick for 3 days, felt better, lost his sense of smell. I didn't even have him go get tested. He's in Denver. I said, you have COVID. I mean, I was sure of it. He had traveled on a plane a week before. This is in late February, early March. And now he actually did get antibody testing because he wants to donate his plasma. So 85% of people will have mild to moderate disease. About 15% will be significant enough to be in a hospital, and about 5% will end up on a ventilator. Mortality by age, this is from the Washington Post about 3 weeks ago. This is mortality by age. So of those 85 and older, about 40% mortality, 75 to 84, 30%. And as you get younger, your mortality decreases significantly. But I think this is also helpful because I think people presumed if you were over 65, it was a death sentence. That's not accurate. And again, believe me, 23% is not a small number, but it isn't as high as I think they first thought, at least from Italy and from overseas. What happens if you get really sick? This is just a quick overview that what happens is, remember we talked about those cells at the top in this is a lung cell up here. And as you'll see, the little thing that looks like it's got fingers on it, those lung cells, when they get damaged, the lung can't hold the oxygen in and it gets leaky, and fluid literally leaks out and gets into your lungs. And that's what happens with severe disease. And again, if you have enough viral activation, this can occur and you can get multi-organ failure and develop shock. What about treatment? We hear about all these drugs. We're going to quickly walk through each of them briefly. Here are the drugs you've read about: chloroquine, azithromycin, that combination, remdesivir, which has got a lot of activity recently. Then there's another, ritonavir, lopinavir is an AIDS drug. Tocilizumab, which is a rheumatoid arthritis drug, and plasma. All of these have been in the news in the last week. What do? So here's what they do. This is hydroxychloroquine on the top. The chloroquine's in the green. What it does is it blocks the virus cell with the little, you can see the virus up top. It blocks it from binding to this receptor right here that looks like a little hand holding it up. So in principle, hydroxychloroquine given early might be effective. Is that how it works in malaria? Because that's what it's been used for 40 years. We don't really know, but I think if it's going to be effective, it probably should be given early or even preventatively. There are 2 studies going on, one at Duke, one in London, where they're giving it to healthcare workers to see if it prevents infection. Is it going to? I don't know. There are a lot of issues with side effects. It can affect your heart. I don't think anybody should do this unless under a physician's supervision, and anybody who is over 50 should have cardiac monitoring. The other drugs that work, the one at the bottom, ritonavir, lopinavir, it's an AIDS drug. What that does is it prevents an enzyme that helps. Remember I said the viral cell takes over the manufacturing inside the human cell? It basically blocks that production. But most importantly, remdesivir, which is toward the right, it's a drug that works after the virus is already in the cell. The virus is starting to replicate. It blocks the enzyme that lets the virus replicate. That's the drug that it was in the last week has been published saying it looks like it really is effective, and especially for very ill people. And it is now approved for use. Several of the local hospitals were part of the studies, both Inova and Virginia Hospital Center were part of the remdesivir study. And the only problem now is getting access to it because, of course, it's wanted all over the country. And later on, these other drugs, which I'm going to basically just say, they work in different stages of infection, azithromycin and tocilizumab. So finally, convalescent plasma treatment. You take people who've gotten COVID, they get plasma, it's got antibodies, you go to the Red Cross, this is how it's done right now. Red Cross takes your blood, gives the red cells to somebody, takes your plasma and donates it back to the hospital. And the small studies that have been done show it really is effective, which is not a big surprise because this has been done for 40 or 50 years, where you use people's plasma to give neutralizing antibodies. Now, if you've had COVID-19 and you have antibodies, does that mean your immunity will persist? I think that most of us believe that it likely will, but nobody wants to get on 60 Minutes and say 100% that's going to happen. But based on COVID SARS, which was the infection from 2003, 2004, people who had that still have immunity 17 years later. And COVID SARS is, remember as we said, about 80% similar to COVID-19. So I think we all believe it likely will happen, but nobody is going to get out there and say that as of today. Future, what's going to happen? One of a couple of things. One, it abates as a result of our current containment. Probably not very likely. Two, there's a population exposure and immunity so that you get herd immunity. What they're striving for in Sweden is to get enough people with immunity such that the frequency decreases and most people don't get it. The US is probably going to have, I've heard estimates of 50 to 100 million people to have that happen. It's going to take a bit. And that's not our philosophy. Third, rapid approach with diagnosis and contact identification. That's what we're striving for. Rapid accessible diagnosis with treatment. If remdesivir, which has to be given intravenously, unfortunately, or another rapid treatment turns out to be effective, that would be terrific. That's what we're banking on. Or we identify people who are immune through antibody testing. The new normal is likely going to be reduced contact with masks and gloves. Vaccine, I've been very impressed that we thought 4 weeks ago it was going to be January, February, or March of 2021, based on research done in England at the Jenner Institute and here in the US at one of the US pharmaceuticals. They're talking about trials beginning in the fall. But remember, let's say a best case scenario, it's available for a trial in September, October. You need 30 days for after you get a vaccine, typically for immunity, 30 to 45. So I don't think we're going to get successful abatement till at the earliest mid to late fall. And that's being very optimistic. And I think, Ken, that's got it.
Right. Great. Thank you. That's terrific. That was really helpful. Yeah, I really appreciate that. Hopefully makes things a little clearer for everybody. So yes, that was a good review, which I think leads into our questions very well, hopefully. So these are mostly questions that we got from our patients, and we can adapt them however we need to as we go through. But I'll just go through these one by one and hopefully get to them as best we can. And again, thank you very much for that. So one person asked, and this is sort of the grand question that we're all wondering. They want to know, how will we know when it's safe, once again, to see our kids and grandkids in person?
Great question. And one that I ask myself, having 2 little grandkids. So the way I look at it is, give me an example. I got a call from a patient about a week, 10 days ago. She's been, up until recently, was watching her grandchild 1 day a week. She said, I haven't seen him in a month. What do I do? I said, what's their status? She said, well, they're sheltered at home. And what about you? She said, well, I'm sheltered at home. And I kind of look at it as like, remember Venn diagrams from grade school and high school? You try to overlap. I mean, I think that you're going to take your nucleus, your nuclear family, whether it's 2, 3, or 4. I think at some point I look at it as, at some point, we're not going to go like this for 6 more months. Likely, we're not going to live, I suspect, in the way we've been for the last 6 weeks. We already can see that. If you're out on the roads now, you're seeing fatigue is already set forth. But I think we'd be smart about it. So I told her that I thought it was okay for her to go and watch the little one, because the little one is not with any other children and has been isolated. Now, how do you handle, as in my situation, I have 2 grandkids in California. Probably not going to happen anytime soon. It's going to require flights. And while children don't get it, I can't put all our patients at risk because if they all fly here. So I think the answer is we're all going to have to make some tough decisions about how long and how much. But I think if, for example, in my situation, if they came and were apart for 2 weeks and isolated, I would then have them able to come and spend time with us. And I'd feel comfortable with that. But that's not easy to do. Puts them at some risk, even though they're 30 and healthy. But still, I think we all have to, I think any new change in your situation, if you're at an at-risk group, does require you to isolate and quarantine. If you're in a vulnerable population. As we know, we've all read, what did Sweden do? They said, well, let's just open up as limited. They're not wide open, but I also think that Sweden is not the US. Sweden is a single culture. And I'm not trying to be cute when I say, I suspect in Sweden, if they said, everybody go get 1 roll of toilet paper, that's what would happen. I worry that we tell people that here and somebody goes to buy 100 rolls. Right. And I say, well, we're not Sweden. I just don't think I don't think we can pull that off.
Right. And we've been talking about this. I think what it comes down to is, you'll never get your risk to 0 unless you lock yourself in a room.
Correct.
Probably not going to be a risk at 100%. You just want to lower your risk as much as you can while still living your life to a certain degree, but be smart about it. And so,
yeah. Agree.
Everyone, and where that point lies is an individual decision. So, the next question is something that's been new in the news. Is about this was just recent. Was about the heart disease. I believe they're referring to. I think it's a Kawasaki's disease in children. I don't know if you were aware of that and what you know about that.
So my understanding, we talked about this morning, was there are some. There have been outbreaks. What I can't tell yet is this a non-specific response to a viral infection? In other words, is this COVID-driven, or is this a cluster? In other words, this is a virus that's very active right now, and in children doesn't manifest itself as COVID-19, but is it a non-specific inflammatory process of which Kawasaki disease is how it manifests, because COVID is the current virus that is most active? I still think it's extraordinarily rare. What are they, under 30? Is that what I read?
I saw about 100 patients total, maybe, but very low.
Yeah. So I think that the conversation I had this morning with an infectious disease doctor from the West Coast was, we don't know. But his theory was that maybe it's a non-specific response to the current virus that's most prevalent.
Okay. Yeah, we'll keep an eye on that one.
Yeah.
Somebody asked you, what is a circumstance where you feel it would be safe to bring an elderly relative to a senior living community?
Yeah, I don't think we're there. So I think that's probably, the first outbreak we had was travelers, and now I don't think there's a single, there's not a single nursing home in this area that is free of COVID that I'm aware of. And some have a remarkably high number of cases. The retirement communities have actually, some have done a much better job. I was at one visiting a friend recently, and I don't think they would, I was masked down, just to walk through the door, and they had everybody with Purell. They took their name, they did a temperature. I was very impressed at this one facility. It's not a nursing facility, it's a multi-level retirement community. And I thought they did a great job. And they've had, I think they've only had one case out of the hundreds of people there. But for the most part, if you say retirement community, at present, I'd be, they're not, I don't even know that I don't know how much is moving in or moving out right now anyway.
Right, I'm sure. Right. And this is more up your alley. So it's somebody asking you to explain the difference between asthma and COPD, and is there a difference in vulnerability to COVID-19?
Yeah, that's a great question. So the answer is yes, there's a difference, a major difference. Asthma by itself, well, let's talk about it. So asthma is simply narrowing of an airway. If you think of of a breathing tube like a tube, if it constricts and opens up again, that's kind of what asthma is. It'll constrict, but it'll open back up in principle to a normal level. COPD is damage to the airways where it's not reversible. So as it turns out, COVID-19, in terms of risk factors for severity, asthma does not turn out to be a significant risk factor for mortality and even morbidity, but COPD is. So if you have asthma, I would have no significant increased worry. And these are for people with asthma that are not on chronic steroids or immunosuppressive drugs. It's just 99% of people with asthma. COPD does have increased risk of severity because you've lost some of your immune reserves, so to speak, but not asthma.
Does that include asthmatics who are on a steroid inhaler?
It's a good question. I think steroid inhalers are not felt because honestly, most people with mild to even moderate asthma are on a steroid inhaler. So we haven't found that to be a significant increased risk. Okay. So I'd say the answer is it is not an increased risk.
Good. Okay. And are there any exercises, breathing exercises or other kind of exercises that can help prevent or improve outcomes if you do get COVID?
You know, there was something someone forwarded me and said it was, and I'm sure there's a lot of people, I'm sure you get the same thing, and I'm sure a lot of your patients get these things from social media. It was this weird exercise about taking breaths and blowing out, and it didn't make any sense. And the answer is, I don't know of any exercise that will reduce your, it will increase your resistance or decrease your severity, other than obviously, staying active, which I think is better for all of us. There's an issue now with, you may have read about this, Ken, I'm sure you have, increased blood clots with COVID-19. And so, I think that it's probably a non-specific response to all the inflammation that happens. So I think keeping active, making sure if you have any other comorbidities that your patients call you, because simply staying at home may not be enough. You might even consider, some degree of blood thinners in people who have some degree of risk for that.
Right. And sitting and doing all these Zoom calls probably doesn't help so much either, right?
Tell your patients to stand up while they're
stand up while doing, yeah. If you're doing a Zoom standing call, right? So a standing desk. All right, great. And somebody asked, obviously everybody knows you should be wearing face masks. Should they be getting specific certified face masks or medical grade face masks if they use something just at home, and where do they get these?
Yeah. So when this first came up, people would say, should we wear masks? And the answer was, well, no, we don't think it offers much help. So the surgical masks that we wear help prevent you from giving it to people, but not you from getting it. They may help, I shouldn't say it, 5-10% they think maybe, but if everybody wears one, then you're not going to get it from someone else. I think that's the concept. It's sort of a herd mentality. If we all wear masks, we're not giving it to people. But if somebody who has it isn't wearing a mask and we have on a regular surgical mask or a cloth mask, we would likely get it. I mean, it's not very protective. So the first reason they said that was there simply were not enough surgical masks. There just weren't enough. And I suspect it wasn't like toilet paper. I think they realized it was gonna, if they said that, there wouldn't be any for the healthcare workers. The second part is the N95 masks, which there still aren't enough. In principle, an N95 mask offers you more protection. It just does. That's why healthcare workers wear them. But there just aren't enough. And even in hospitals, they're in shorter supply. So I think the concept, what Dr. Fauci says is we're reserving those for healthcare workers. I think that's helpful to understand that. But if everyone wears a cloth or a surgical mask, if everyone else is wearing them, you would be safe. The problem is not everybody is when they're outside. So I think, the N95 masks they sell online, most of them, I think it's kind of like fake Gucci purses. They're knockoffs, and I'm not sure how reliable some are. I've had people bring them into us, and they say if it holds water, then if you take a mask that you buy and it can hold water, it's probably better. Some of them don't even hold water. So anyway, it's a long answer to a question of you'd probably be better with an N95. The problem is if we all start wearing them, there will not be enough for the people who need them.
No, that's a really important point.
But if you wear a surgical mask or a cloth and people around you do, you will be as safe. And that's important to remember.
We're all in this together.
Yeah.
Great. And then that gets into the next point here. So obviously, Governor Northam has declared that we're going to be opening up Virginia to some degree. I believe it was next week. And how do you think that's going to look? Is that going to change where we are now, and what's going to happen with the number of cases as we do that?
So Northern Virginia is now in a fairly large resurgence. So what happened is it had dropped about 2 weeks ago, and in the last 10 days, we've had a large increase in hospital cases and in new diagnoses. Now, is that because we're testing more? Well, that testing more would mean more cases, but more hospitalized patients mean, and I think the hospitalized patients tend to be those at more socioeconomic risk. The current hospitalized patients, both at George, I've talked to the director at MedStar, Inova, and Virginia Hospital Center. All three are experiencing the exact same thing. And that's probably not a big surprise because they have less reserves, have less ability to isolate, and have more requirements to have to try to work and get out. And, recommendations were try to have 2 weeks of food. You know what? A lot of people, there are many people who cannot afford 2 weeks of food. So they have to go out and get food every 2 or 3 days at the most.
Right. As I understand it, we're still, the key is to keep under the max abilities of our hospitals. And so far we're still there.
Yeah. So your question was, what do I think? I think that the current I think what they want for the government is they want to have 14 days of continued decrease. We haven't started that yet. It hasn't started. So I get it. And I mentioned to you before we spoke, there's a great talk by a guy named Dr. John Ioannidis, who is at Stanford infectious disease. He's their infectious disease guru. And, he argues that we have to be careful because the more people you put out of work, he did an editorial, he's gotten some play on CNN, and they kind of bait him a little bit because he's a kind, thoughtful man. And he says, no, as a doctor, I have to be aware that when when people don't have income and don't have funds to buy food, we have to look at the biggest picture as well. And it's not saying that we just open up and let people do things. There's probably a balance there, and we have to have thoughtful, sensitive people helping to make those decisions. And it's where we are.
Right. Yeah, that's a good point. Yeah, we have to make sure we keep everybody safe as much as possible without the expense of having people die from other things.
Correct. Yep. Exactly. Ken.
Right. And there's been a lot of talk about pulse oximeters and their utility if you can get them. Do you recommend these, and how good are they?
So I'd say that most of them have been pretty good. When we are screening, when we're talking about reopening certain places, let me pick on football. We have players that are at large body mass individuals who maybe at some increased risk, best we can tell. And that question has come up, should we be screening people with oximetry? And that question is not answered yet. Should it be part of a screening tool? I think it depends on the population. If you've got a young, healthy 25-year-old, probably not. But we have seen people with large body masses who may have low oxygen saturations and not even be aware. So I think for certain people, measuring temperature, symptoms, and oximetry may be reasonable, yes. I think it's gotten a little easier to get them, but I agree, it's not, we're not there yet.
Right. All right. Yeah, that's been a recurrent question for me and my patients.
Yeah.
And have you seen any after effects, pulmonary effects from COVID after the people have resolved?
Yeah. So I think that there's some papers that are out that show that I tell people when you have pneumonia, a regular pneumonia, not COVID, it takes 2 months for the X-ray to return to normal, up to 2 months, depending on your age. So it's not surprising that the COVID that's been in this country for barely 2 months, we're still seeing X-rays that are not back to normal. That's not a surprise. The people who've had severe COVID, their X-rays have not returned to normal, but I believe they, like severe pneumonias, they likely should return.
Sure. And one more question somebody asked, what is hyperinflation of the lungs and is it related to asthma?
Yes, so hyperinflation is, if you have asthma, remember we said before, if your lung's like a tube and you try to blow air out and the tube is constricted, think of it conceptually as conceptually the air can it backs up, so to speak. It's almost like taking a deep breath, you can make your lungs look hyperinflated. It's like a balloon that you've blown up too much. That's what hyperinflation is. As people age, it is a normal part of aging to get a little bit of hyperinflation. And COPD, emphysema, one of the hallmarks of emphysema is a hyperinflated lung. But it by itself, hyperinflation, if I had you take a really deep breath and hold it, I could make your lung look hyperinflated on an X-ray. So it just depends on whether it's a phenomenon of what you're doing to make it look that way or whether it's a manifestation of disease. And I used to get consults when a radiologist would put hyperinflated lungs, consider this patient having COPD emphysema, and inevitably they didn't. But so by itself, usually not a major issue.
So that's most of the questions that everybody else has put out. My own personal question is, do you have any updates on the upcoming NFL season? And how are you guys going about trying to decide what to do?
Sure, it's a great question. I was on a call today about it. So it's actually a good window into the social cult and what's going on in America, because, I think one of my friends who's not a football fan said, you know what? I'm not a football fan, but it's important to so many people to have outlets, to have this as part of our life. It's like, baseball, football, these sports, it's important. And so it gives us a sense of normalcy that we all need. So I think that my sense is we are operating on the principle that there will be a season. I think that by September, we will have a season that we are planning to start on time. In fact, I think tonight they're releasing this schedule.
Right, I heard that.
And so might they have to adapt and adjust? Maybe, but I think that they're hopeful. Will there be fans? That's a tougher one. I think that's a harder, I don't know that anybody could project they're going to be sitting next to 75 or 80,000 people in 3 months. But playing football like they're going to try to play baseball without fans, I think that's certainly doable. Fans, how they've worked that, I think is going to be a tougher thing to handle, at least early in September.
Yeah, maybe not quite as important as COVID, but very important to a lot of us. Yeah, thank you for that. Yeah, I appreciate it. And so, and with that said, it relates to everything, recreational sports, amateur sports, all of us. We want to know that's a great microcosm for everything else that's going on. Yeah. And so finally, if you wouldn't mind, as I said earlier, you always have fantastic stories to share, and I often share stories you've told me to other people. Do you have any stories that you'd like to share with our patients today?
It's funny. The one I think I've told you before, I was on the sideline once, and one of the players who is currently now a reporter on sports TV, he denies that he ever did this, but this is exactly what happened. So he gets hit he's a safety, he got hit in the head and came off the field. And I'm just very protective of I look at these like, if my rule is if I wouldn't let my son play in a game, I'm not letting you play. And so came off the field, and this was about 10 years ago. And I said, you know, how are you doing? He said, I'm fine, I'm fine, I'm fine. So I asked him questions, and I said, okay. I gave him I told him, all right, apple, penny, bubble, table. I'm going to come back, you know, I want you to remember those things. Repeat them now. I'll come back in a couple minutes. So I come back a couple minutes later, and he's taken a marker like people used to sign autographs. And on his leg, he wrote apple, penny, bubble, table. And I said, really? You're out. He goes, why? I said, because if you think I wasn't going to see that, then you must have a concussion and you're out. He was mad at me, but that's okay. But anyway, but my story that I think you heard earlier, which is my favorite, and I can only tell now because you'll hear why. So about, I don't know, it's maybe also 8 or 10 years ago, I'm in my office, I get a call. I'd done some work through the White House and all the administrations, and I get a call and they said, hey, can you see so-and-so? I told no one he was coming except my one nurse because I was privacy, et cetera. And the Secret Service used to bring him in the back door, people who came, but I had never seen him in my office. So they bring him in the back door and I see him and I'm finished seeing him. And he goes, hey, doc, are you free for lunch? And I said, no, Mr. President, I'm not. I said, it's 11:15. I still have a patient to see after this. And he said, my favorite Thai restaurant is right down the street. And I said, well, honestly, I think you just need to go home. You're not really as well as you should be. And he said, what about takeout? And I went, well, yeah, you can get takeout, whatever. So I started to shepherd him out the back door. And he turned to me and he goes, where's your waiting room? And I said, oh, it's at the other end, sir. And he turns around, he walks down the hallway, he starts knocking on every exam room door, opens the door. There's people in gowns, they're half dressed. He shakes their hands. How you doing? Nice to see you. Gets to the waiting room, works the whole waiting room. So that's why I can tell you the story. So that was very sweet. He's the nicest man ever. About, I don't know, a couple days later, maybe a week later, I get a call from a patient and he says, you know, I'm sorry, I was there with my mom and I dropped her off and I had to wait for her to, you know, you were waiting and she's been really, I know she's got some mild confusion, but she keeps talking about talking to the president while she was there. And it was 41 who is a sweet man, very kind. And I think they just can't help themselves.
Right. That's how they get to where they
are. By the way, it now has occurred to me as I tell this story, he wasn't well that day. And I worry now as I'm telling the story about who else got ill as a result of his shaking hands with everybody. Now that we're so conscious, you know, that didn't even occur to me till now.
Right, yeah.
Anyway,
this is going to be the first presidential election where everyone is super aware of that kind of campaigning. Yeah, it really make a big difference this time around.
So anyway.
That's great. Thank you so much. Yeah, that was
and I'm very impressed at your practice and what this is really nice to be able, your patients must really appreciate it. And it's a lot of effort to do this from you all. And it's really a terrific thing that you're able to do.
Well, thank you. And it's a really terrific that you were able to join us. We really appreciate it. And it's a pleasure to keep this going. Like I said, our goal is just to keep everybody informed and safe as best as we can.
Yeah.
So I really appreciate that. Thank you so much.
Okay. All right, Ken. Take care.
Take care. All right. So
I'll sign off and let you keep talking.
Thank you. That's great.
Thanks, Tony.
A little bit more. Thank you, Tony. Thank you so much. All right. Hopefully that was helpful for everybody. That was really very exciting for me. He's such a mentor and somebody I really look up to. So that was very exciting for me. And so before we go, we just want to do one more thing. We're going to have Dr. Beauvais, our CEO, talk to everybody about the steps that we're going to take to keep everybody safe at our new location when we move. So, Dr. Beauvais.
Thanks, Dr. Zweig. So thanks all 100 of you who joined us today. I'm really, really thrilled that we're able to reach so many people. I know there are a few questions that have not gone answered, specific questions that came in during this seminar and also that come in on email. Usually afterwards we get a few others. So really specifically, especially if it's related to your care plans, please call and talk about it with your care provider, because each decision has to be unique to your situation. And if it's a decision about whether or not to do a procedure, it really, really matters to talk to you about what your needs are. I've had high-risk patients have procedures last week. It depends on what's going on. Sometimes we're going to be able to delay until September. So let's talk about them individually with whoever your doctors are. So for our office, I mean, the biggest thing that you'll notice is it's in a new location. You'll have to kind of meander and find the new parking lot, and we're up on the 4th floor. The biggest thing you'll probably realize is that you're going to be asked to behave differently. We're going to ask everyone to be wearing masks, and everyone will be either sanitizing their hands or washing their hands when they come in the door. We're really lucky that we have a spacious office, but also a non-rushed office. And so we're really going to be able to have people stay in either one of the separate 3 small waiting rooms or go right into an exam room. So we won't have anyone waiting with another family at the same time. Our staff looks different now because we are wearing masks 24/7, except like all of us right now are in our homes. So in the office, we'll be wearing masks. We'll be wearing gloves when we work with you. You'll see hopefully a lot more hand washing, and we will be staggering our visits. So first of all, there's no pressure to come in. If it's not the right time for you to come in, there's no pressure to come in. But when you do need to come in, and when you do decide to come in to get some of your preventive health taken care of, we will be able to space that out with other people that we'll be seeing at home. So there will be thorough cleaning between all of the visits. And that's really important to us for many reasons. I mean, we're in healthcare and we want to be able to continue to see you and stay open. We want you to stay healthy and we want us to stay healthy. So you have to wear a mask for us and we'll wear the mask for you. Please call. We talk to every single person ahead of time to find out what their symptoms are, whether you're healthy and coming in for a blood pressure check or whether you're not feeling well. All of the people who don't feel well will be directed to a different part of our office where we will have people who are not well. And probably, an odd manifestation of COVID has been that we are really treating sick people at home. And so in some cases, we'll still be able to do that. We'll still be able to talk to you on the phone and start with a video visit and then bring in the people that need to come in for further care. So I think that's mostly it. It's slower schedule, hand washing for you, face masks for everybody, and we'll be cleaning all of the surfaces in between all of the visits. No longer will we rely on the little paper veil that was on the exam table. Everything will be thoroughly cleaned after every patient. So I think that's it. We'll be moving a week from tomorrow. So we will be, to reiterate what Dr. Zweig said already, we'll be closed on Friday, May 15th. The doctors will be on call in case you need us for an emergency. We'll be available to you. But the office will not be open that day, and we will reopen on Monday, the 18th. And we'll certainly post a video tour so that since we can't tour you all through the office, we'll at least give you a little bit of a glimpse inside once it's all complete and we're there in about 10 days. So thank you all. Thank you, Ken, so much for that great hosting job. Thanks for inviting Dr. Casolaro. And it would be fun to hear from him again sometime. So hopefully we can revisit that.
That's great. Yeah, no, it was really fun for me, and I hope it was helpful for everybody out there. And thank you, Natasha.
All right.
All right. Keep the questions coming.
Be well.
Be well. Take care.